Hello everybody, good afternoon. Hope you all enjoyed lunch. So we're now ready to start after a few technical issues. So I'm Jack Stone, I'm one of the chairs of this session. I'm a mathematical modeler from the University of Bristol. I think we've got a great session of talks, I'm really excited.
Thanks, and my name's Kriana Barat. I'm a biostatistician and a PhD candidate at the National Drug and Alcohol Research Centre based at UNSW Sydney. So just a little bit of housekeeping for today's session. I'd like to say hello to everybody in the room, but also our virtual audience, which we're so glad that you're still able to join. If you would like to ask any questions during any of our sessions today, please submit them through the conference app. To our virtual audience, you can also submit questions via the app or type them into the box on the right-hand side of your screen. Please visit the INHSU cinema in the exhibition hall. If you haven't already, it will be open throughout the conference. Simply pick up some of those headphones, take some time out to watch INHSU's selection of short films on hepatitis C models, some of which we saw this morning, on care and drug treatment options from all around the world. All films were told by the visual storyteller Connor Ashley, who spoke in this morning's session. Please also join us for the poster tours taking place in the exhibition hall at 3:40 p.m. today, so just after this session. Again, you can grab a headset to listen to those, apparently. Without any further ado, I will introduce the first speaker of today's session. Nikki Jones is a biostatistician currently researching the incidence of adverse events from opioid agonist treatment in New South Wales using linked administrative data. Thanks, Nikki.
Thank you. Good afternoon, everyone. Okay, so I'd like to share with you some findings from the opioid agonist treatment safety study that we've been conducting in New South Wales. And this particular study, we were comparing non-fatal and fatal overdose at different exposure periods during treatment. First, I'd like to acknowledge the co-authors of this paper. So it's already been published in Drug and Alcohol Dependence earlier this year. It's also a data linkage study. So it uses health administrative data. So I'd like to acknowledge the data custodians that have provided this data to us for us to do the analysis. And here we've got our disclosures of interest as well. So first, a little bit about the opioid agonist treatment safety study, or we call it OATS for short. So in New South Wales, we have a database that contains everybody that has had opioid agonist treatment since the beginning, really. So this data has been provided to us. So for this analysis, I've got everyone that has been on the opioid treatment program in New South Wales between 2002 and 2017. So I've got 15 years of data. And these people that have been on opioid agonist treatment have been linked to some health administrative databases as well. So we've got hospital admissions, the emergency department presentations, corrective services, the mental health outpatient data, and the National Death Index. So we have a good, rich information about how these people have been interacting with services over the years. So for the aim of this study, we wanted to compare the incidence of overdose across 4 distinct exposure periods of a client's treatment history. So we've got the first 4 weeks in OAT, the remainder time on OAT, and later on in the modelling, this was our reference level when we're looking at rate ratios. The first 4 weeks following cessation of treatment, and then the remainder time of treatment. So the first 4 weeks on and off have been selected because they're known to be critical periods of risk. We also had 4 overdose outcomes that we were looking at from this data that we were provided. So we've got non-fatal opioid overdose, and this is from the hospital data. So this is only those that then got admitted to hospital. We've also got fatal opioid overdose, so that's from the National Death Index. We also were looking at non-fatal, non-opioid overdose. So the first one, where we're looking at non-fatal opioid overdose, they had to have had an opioid in the clinical diagnosis, but they could have also had other substances listed. But for this third one, Part C, the non-fatal, non-opioid, there was no opioid in there, so it could have been any other substance, which would have been a sedative, a stimulant, or alcohol, or a mixture. And again, these are hospitalizations. And then the final one I looked at was the emergency department presentations. Now, you only get one diagnosis recorded in the emergency department presentations, and there isn't enough information to be able to determine whether it's an opioid or another drug. A lot of the records just state that it was an overdose. So these are being grouped together. Now, I understand that a limitation here is a lot of overdoses are actually dealt with by ambulances and first responders. But we're just looking at the different time periods for these hospitalizations and the National Death Index. So the method in the analysis, so I am a biostatistician, so I'll try not to go into too much of the stats. I probably should have taken this one out. We were looking at crude incidence rates, and we also then looked at adjusted incidence rates and ratios using Poisson regression models and generalized estimating equations. So in order to do that kind of analysis, you need to calculate person time. So it's the number of days each person was in OAT or out of OAT, and then broken down by their first month of treatment or off treatment and the remainder time. So person time started when they first entered the cohort, and it ends on the 31st of December 2017, or if they died, or 4 years after the last OAT episode ceased, so whichever occurs first. And then we just count up the number of incidences that happened within that person time. So a little bit about the people in New South Wales that are on opioid agonist treatment. In this, between 2002 and 2017, we had just over 45,000 people on the opioid treatment program. They entered the cohort at 32 years. 58% had been hospitalised for substance use disorder, 47% for a mental health outpatient activity, 11% self-harm, and we've got 15% had been hospitalised for non-fatal overdose. 37% of this cohort had been incarcerated during that follow-up period. We had 6,000 deaths, of which 25% were due to overdose and 3% due to viral hep C. Another thing about those 1,400 overdose deaths, 47% of those had been hospitalised for a non-fatal overdose prior. So I want to draw your attention to four things from this plot. So this is just the crude incidence rates for the four outcomes, so non-fatal opioid overdose, which is on the horizontal axis, going to the non-fatal overdose for emergency department. And then we've got each of the markers indicates the exposure periods. So we've got 4 exposure periods for each of the 4 outcomes. And then on the vertical axis, we've got the crude incidence rates per 1,000 person years. So each of the markers is the crude incidence rate, and then the error bars that come out of that marker is a 95% confidence interval. Okay, so I want to draw your attention to 4 things from this plot. So we'll start with the first. 3 out of 4 of the outcomes that we were looking at showed the same pattern, as in the highest incidence rate was in the first month out of OAT, and the lowest risk of overdose was in the remainder time in OAT. And then the second highest risk period was the first month where they started treatment. So these 3 outcomes had a similar pattern, different magnitudes, but a similar pattern when it came to the 4 exposure periods. So the second thing I want to draw your attention to is that the incidence rate of overdose was actually higher for non-fatal, non-opioid overdose than it was for non-fatal opioid overdose. Now, bear in mind that does include alcohol hospitalizations as well. So the non-fatal, non-opioid overdose was highest for the 3 exposure periods, except for the first month of treatment, where opioid overdoses increased more than the non-fatal, non-opioid overdoses. So a slight difference in what we were expecting there. The third thing that I'd like to draw your attention to is when we look at non-fatal opioid overdose, the highest or the most riskiest period is that first month in treatment. The lowest is the remainder time in treatment, but this is where they differs from the other three outcomes, that the risk period is highest in the first month of treatment. And gladly, we don't see that pattern when it comes to fatal opioid overdose. Okay, so there's the highest risk of non-fatal opioid overdose is in the first month of treatment, but we don't see that for fatal opioid overdose. The highest risk is the first month out of treatment. Okay, so I said that we did generalised estimating equations. So the main aim of the paper was just to compare those three exposure periods with the remainder time in OAT. So all of these are showing that they are similar, as in on the right-hand side of the dashed line, which is 1, our reference line. So these are adjusted rate ratios. We're comparing the three exposure times, the first month out of OAT, the first month in OAT, and the remainder time out of OAT with the remainder time in OAT. Okay, so everything is on the right-hand side of the reference line, which means the greater risk is in the other periods compared to the remainder time in OAT. So retention in treatment is best, basically, which is what I'm trying to say. At the bottom of that plot, we've got all the covariates that were adjusted for in the model. So we have some at baseline, and we have some that are time varying because they change, and we were creating covariates that looked at incidents in the last 12 months, and that was modelled in our generalised estimating equation. Okay, so there's similarities there. And then the final thing, so this is just a little deep dive. It was like a third aim, looking at buprenorphine versus methadone, because we want to have a look at what was driving that high risk in the first month in treatment. Now, bear in mind this is a retrospective linkage. It's not a randomized controlled trial, so there will be treatment selection bias at play here. People on methadone aren't necessarily the same as the people that are on buprenorphine. They might have more complicated stories. But we can see, and it's highlighted in the box, that the incidence of non-fatal opioid overdose is is twice that of buprenorphine in the first month of treatment. But I'd also like to draw your attention to both of those are also similar to the first month out of treatment. Okay. So the implications of this analysis is why is non-fatal opioid overdose highest in the first month of OAT? Is this due to dosing? Should slower rates of methadone be introduced, as this does appear to drive the elevation at treatment initiation? Is there other substance use at play, which we've already seen because that has a higher incidence from the crude incidence rates that we were looking at? So is the elevation due to polysubstance use, which may be driven by insufficient dosing? Or how is other substance use being addressed at treatment initiation? Also, why is non-fatal opioid overdose elevated early in OAT, but thankfully we don't see that for fatal opioid overdose? Is that OAT being protective, preventing fatal outcomes with toxicity? Is it due to the provision of take-home naloxone? Is there a role for additional symptomatic medication to be used during treatment induction, or revision to the standard dosing protocols? So it's kind of drawn up more questions than answers, but these are just interesting things that came out from this study. So, like I said, it's already being published in Drug and Alcohol Dependence if you wanted to know more, or you could email me. I do have a Twitter account, but I really don't really know how to use it, but feel free to give it a go. Thank you.
Thank you, Nikki. Are there any questions in the room? So you can use the app, or there are two microphones in the middle of the room. We have got one online. So Brian Stevens asks, your data shows that 3% were hepatitis C positive.
Yeah.
Can you tell us what proportion has had a recent test?
Sorry for that again.
What proportion has had a recent test?
See, unfortunately we don't have the data for testing, although the new linkage will. No, actually that still won't have testing either. Yeah, so that's something that's not available in our data that we were provided. So, sorry, can't answer that one.
Nick, can I ask, you've got data over a very long period.
Yes.
Did you look at whether any of your mortality rates had changed over that period? Or did you just look at fixed rates across the whole period?
It was a fixed rate. There was a previous paper where we looked at, actually there was non-fatal overdose over time, but we didn't look at that over this period. In Australia, we do know that it is increasing over time, but I didn't look at that for this study.
Thank you, Nikki. So our next presenter is Dr. Magdalena Harris, who is an associate professor in the sociology of health at the London School of Hygiene and Tropical Medicine, and she will be presenting on barriers to management of opioid withdrawal in hospitals in England.
Cool, thank you. It's a pleasure to be here and talk about some exciting findings from document analysis, but also developing a new policy in collaboration with London College Hospital. So, in terms of disclosure, so on the authorship team we have, proud to have Neve Eastwood, who has Works for Release, which has received a grant from EpiPharm, and all other authors have no conflicts of interest to declare. And we'd like to thank all the community members of lived experience of injecting drug use have contributed to this research. Okay, so the impetus for this study came about from a previous study that I conducted, which was looking at skin and soft tissue infection prevention, care and risk. And we conducted a survey amongst 455 people who inject drugs in London between 2017 and 20. And what we found is that there was a high reported lifetime prevalence of skin and soft tissue infections amongst this population of 68%. But also what seemed to me to be really quite shocking was the high proportion hospitalised for what are essentially preventable conditions, abscesses, ulcers, cellulitis, etc. And so 44% of those with a skin and soft tissue infection reported being hospitalised for that infection. Hospitalisation was associated with care delay, with over half taking more than 5 days to present to hospital after first noticing a symptom, and nearly a third taking more than 10 days. And we also conducted qualitative interviews with a subsample, 37 people who inject drugs, and asked them in depth about their experiences of skin and soft tissue infections, hospitalisation, etc. And what came out here is that fear and experience of opioid withdrawal in the hospital was a primary barrier to treatment presentation and also completion. So we had people talk about, so this guy here says this was the thing that scared me more than anything, was being sick in hospital, the irony. The fear of being in withdrawal is one of the scariest things in the world to be. So because of that fear and because of experiences of not receiving opiate substitution therapy in a timely manner in hospital, people felt the need to stockpile money and drugs before they went in. There was a lot of use of illicit drugs on the wards, and also self-discharge was common. So this woman says they give you a dose of methadone in the hospital, but you have to wait for the doctor to consent, so I'm waiting days. She's waiting days. Imagine how unwell she will be. So she leaves, she says, sick as a dog, arm bandaged up, she had a large open wound, and I have to go out and find some money. So we wanted to understand what was going on here. Is this just about stigma? Is it just about nurses and doctors not giving people the medication they need because of some sort of punitive moralising judgment? or is this actually underpinned by a hospital policy? And the first thing we did was we went and looked at hospital critical medicines lists. And in the UK, hospital critical medicines lists say, you know, what medications should be prioritised, what should always be stocked on the ward, what should be given without delay. And on many of them, or the ones that we could access at least, methadone and buprenorphine and medications for substance dependence were not there. So we asked ourselves, what informs the critical medicines list? And this is the delayed and omitted medicines tool that was developed by the Specialist Pharmacy Service to help hospitals create their critical medicines list. So we went and looked at that. And what we found is that drugs used in substance dependence, this was it. They were classed together, they were lumped together for alcohol opioid dependence, no mention of benzodiazepines or any other substance, and the risk was low. It's a traffic light system, you can see here, green, green, amber. Okay, so no big deal if you miss it or omit it. No wonder it's not on the hospital critical medicines list. So then, with Release, who are a project partner, we requested substance dependence guidelines from all NHS hospital trusts using the Freedom of Information Act. And we had 86 trusts provided 101 relevant policies. We had other trusts, and I'm going to go through the whole methodology for this in a little bit. We found there are real discrepancies in approach, a lot of procedural barriers to the timely provision of OST in hospital, and punitive language. So, for example, this was in one policy, patients with a history of drug abuse often have unreasonably high expectations. Alleviation of all pain is not a goal. And this contrasted markedly with the sort of language that was used in guidelines for palliative care, treating pain, you know, for other populations. So what do we do then? So we went to the Specialist Pharmacy Service and said, I don't think we really agree with your categorisation of substance use, and this may be causing some problems. And so we were invited to give webinars to the Specialist Pharmacy Service and the Medicine Safety Officers. First a 10-minute slot and a bigger webinar, and then we had an hour dedicated webinar. And they were actually pretty supportive. And so with them and the consultation with other stakeholders, we managed to get a revision so that we had alcohol demarcated from opioids and including also benzodiazepines, and we increased the risk profile for all of them, which was wonderful. But since then, the Specialist Pharmacy Service have decided they want to revamp the whole thing entirely and have taken it off the shelf, so to speak. But still, that was a win at the time. And we went and talked to people who inject drugs, and we said, what would help make you feel safer to go to hospital, and what would help make you feel safer to stay in hospital? And so they came up with this idea of an advocacy card and a helpline, and with this we created the iHost intervention, which comprises the advocacy card, a helpline, an online staff training module, a best practice policy template, and an iHost champion. So I'm only going to talk about one aspect of this, which is the policy aspect, but feel free to come in and hit me up if you want other information. So back to the document analysis, which our policy template is based on. We contacted 224 NHS trusts. We included 125 of those trusts. We then looked at that. We found that 86 provided relevant policies, and we analysed those using a content analysis, which included community members and was quite a sort of rigorous process. And we have published this, so this is available in BMC Medicine. Now, key findings is that trusts needed to confirm usual doses with community services. This is fair enough, no surprises there. But verification is often not possible out of hours, okay? And only 18 trusts gave other options for when verification was not possible. 17 trusts gave no guidance on what to do, and 6 explicitly stated that no OST should be prescribed at all unless verification was possible. Newer unconfirmed prescriptions, They were usually treated the same as new prescriptions. We had 67 describing a regimen for OST initiation. 5 prohibited it, which I think is really concerning. 14 trusts, there was no mention or practical information of how to initiate OST, and the initiation regimens really varied. 12 trusts limited the dose to 30 mg on day 1 and 2 limited it to 20 mg, and there were often restrictions on subsequent dose increments. So all of these things have implications for whether people are going to want to stay in hospital and how quickly and effectively their withdrawals are going to be treated. There were many procedural barriers to timely OST provision, requirements for particular staff or specialist teams to assess patients and prescribe OST. Now, this might be a good thing, having specialist addiction teams, for example, but it is a barrier if the team is not available out of hours or is poorly resourced. What was most concerning was the requirement for urine drug screens. So 42 trusts required or recommended urine screens prior to OST prescription. 14 required positive urine drug tests prior to OST, regardless of whether it had been confirmed by the prescriber. So the community drug service, the pharmacist might go, yes, they're on it, and they're like, no, sorry, we still want to do a urine drug screen. They might have to send that off to a lab. You know, only 10 of the trusts stated that point of care was available or recommended point of care. You know, so this is a huge procedural barrier, and we saw this in a lot of our qualitative work and consultations with hospital staff as well. There was very poor information on discharge, and you know, there was often not availability of takeaway OST when people were discharged out of hours. There was often no information on facilitating OST continuation, etc. Stigma was pervasive throughout these policies. You know, use of discriminatory terms, misuser, abuser, addict, talking about sanctions, maintaining a degree of suspicion. You know, the sort of language that is not common or seen in policies related to other patient populations. You know, there was requirements for supervised, you know, consumption, supervised urine testing. A maternity guideline stated new mothers must be informed if the test was positive that they might be discharged while their baby remains in hospital. You know, really quite upsetting things like this. So what did we do? We want to change all of this, and you know, and we have managed to create some change, which is really, really exciting. And working in collaboration with University College London Hospital, we have used their guideline as a template, and here you can see their rather disturbing wording of their previous guideline, management of drug misusers, which was probably the first thing to go out the window. And we addressed 4 main issues, and we did this through a really rigorous process that involved a working group comprising people with lived experience, clinicians, nurses, drug treatment, people with drug treatment experience, and then we had oversight, review, discussion with key stakeholder organisations such as is listed there. Because this is to try and change policy, you're going to get a lot of kickback, and we had to try and do it properly. And that took a lot of work and a lot of persuasion, particularly in relation to things like urine drug tests, urine screens, and you know, and a lot of interesting talk. But anyway, I'm going to go on to our key ones that we have. You know, this is just about through. I'm nearly finished, but we have managed to remove mandatory urinalysis pre-OST prescribing. It is no longer a requirement for University College Hospital. we have increased the initial dose from 10 mg to 20 mg. We've increased the first day dose from 40 mg to 60 mg. We've introduced takeaway OST when there was no takeaway OST before, and we have introduced take-home naloxone where there was no take-home naloxone before. And this has nearly been through all of the requirements and signed off. And it's been really well received from clinicians and nurses. As my research fellow said, there were claps and cheers from the acute medical unit staff when we introduced the changes, claps and cheers. So this is really exciting. This is one version of our new guideline, and you can note the different titles there. So I know I'm over time, but just to say that, you know, policy change is possible, and that barriers to care and poor experiences of care are not just due to stigma, but can be underpinned by really discriminatory policies. There are lots of wonderful nurses, doctors, clinicians out there, but if the policy's bad, they're going to be stymied. And so we really have to look at that, as well as working on education and aiming at this from lots of different angles. So I will stop there. Thank you.
Thank you so much for such an interesting talk. Any questions, please feel free to jot them down in the app, or if you're in the room, please, you're welcome to walk up to any of the microphones as well. Yes, would you like to, there's a microphone just behind you there. Thank you.
So Magdalena, can you
Yep.
extraordinary, as usual, beautiful work. Very impressive, honestly, the fact that as an ethnographer and just deep knowledge of the everyday reality of people who inject drugs, you were able to impact the policies in the hospitals. I think it's astonishing. I have a boring question, but I want to ask just because I would love to do what you did in New York. How do you put together the stakeholders, especially from hospital administrators? I imagine there probably was a great deal of resistance. Also, in my experience, the medical providers, the medical community, they are very question the expertise of non-medical experts or professionals. So again, it might be a boring question, but very interested on the process, how you manage to kind of put together the stakeholders in a functional process. And a great word, thank you.
Thanks, that's a great question. I mean, you know, I have to acknowledge that even though I'm this is my baby, it's also, I'm doing a lot of co-parenting with an amazing team. And our story is here from UCLH in the audience, but also we have an amazing clinician, Dr. Mike Brown, who really championed this. And he's an infectious disease consultant, and he just took it on and really helped sell it to people at UCLH. But the process was, as you say, much broader than that. And we had actually quite a bit of kickback from the Office for Health Improvement and Disparities. We basically had to get somebody from these sort of key sign-off organisations and have debates with them, you know, argue the case about each tiny little point. And you know, and just keep on debating it. And we had some kickback from the Office of Health Improvement and Disparities because what we were doing was not in line with national clinical guidance, which they had overseen. And we were like, well, that guidance isn't working. And so we actually went to the chair who oversaw that guidance, was Professor Sir John Strang, and we talked to him and we said, Professor Sir, do you think it's all right if we have a go at amending this? And he's like, yeah. So then we went back to the office for, for whatever, and said, well, Professor Sir thinks it's okay. So, you know, so there was a lot of that, yeah.
Fantastic. We might leave it there. If you've got any other questions, I'm sure that
Thank you.
You're welcome to ask after the session. next speaker in today's session is Dr. Sarah Lani, who is an Associate Professor at the University of Montreal and Research Centre of the University of Montreal Hospital. Thanks, Dr. Lani.
Hello. So before I start, I just want to acknowledge that Nikki from the first presentation in this session did all of the statistical analysis. So thank you, Nikki, and I will defer any very technical questions to her. I didn't tell her that before, though. So just some pharmaceutical funding unrelated to this work to note. So opioid agonist treatment, obviously very effective at reducing mortality among people with opioid use disorder. But most of the formative work on OAT and mortality was done quite a while ago. And the population that was studied tended to be people in their late 20s and 30s. But in a lot of places, like including Scotland, Australia, a lot of other parts of Europe, the population of people on OAT is getting older. So in Australia, for example, in 2021, more than 1 in 3 OAT clients was aged 50 and over. There's actually more people aged over 60 on OAT in Australia than there are under 30. So it's obviously important to understand then whether OAT continues to protect against overdose death as people age. And trying to understand this is quite complicated because of the higher prevalence of chronic diseases as people age, some of which may increase overdose risk in themselves by compromising physiological functioning. So, for example, circulatory and respiratory diseases may increase susceptibility to opioid-induced hypoxia, and liver and kidney diseases may interfere with metabolism and excretion of opioids and other medicines. So we have this ageing population that is also sicker, and our clinical guidelines weren't really designed for this population. So we wanted to make sure that OAT, as it is delivered for this younger population, still protects against overdose in older adults, and also look at whether methadone and buprenorphine have different safety profiles in older adults or those with chronic disease comorbidities. So our first aim was to estimate the association between OAT and opioid overdose death in older adults. And then secondly, estimating the association between OAT and opioid overdose death in the presence of specific chronic diseases that may increase overdose risk. So this was using the same data source that Nikki spoke about, the OATS study. If you weren't here, it's linked administrative data for all entrants to OAT in New South Wales, Australia between 2002 and 2017, with linkage to hospital, mental health, legal contacts and deaths data. So our outcome was fatal opioid overdose of unintentional or undetermined intent, and we assigned deaths to one of these 3 treatment exposures based on the date of the death and the treatment episode start and end dates. So we have quite precise treatment start and end dates. And then we stratified by these 4 age groups. People moved through these over time. For chronic diseases, we included these diseases that I mentioned with a plausible mechanism for increasing overdose risk, and these were defined using ICD-10 codes from the hospitalisation data. People were defined as having a disease from their first hospitalisation for a specific disease and then assumed to have that for the remainder of follow-up. And each disease group was modelled separately, controlling for the other diseases. Obviously, this is observational data. We were hoping to be able to make some reasonably strong inferences around causality. So in addition to the usual covariates, we employed 2 approaches to address the lack of randomisation. So firstly, we prepared generalised estimating equation models controlling for these confounders here. And then secondly, we estimated marginal structural models with inverse probability weighting. And I'm going to massively simplify, but essentially Nikki estimated weights for treatment selection and each time a confounder change, then weights for the probability of remaining in treatment each time a confounder changed, and then estimated weighted repeated measures models using GEE. So those weights went into the GEE models. So there's 37,000 people in this analysis. There were almost equal numbers of methadone and buprenorphine episodes, but you can see that there's a lot more methadone person years of exposure than buprenorphine, and that reflects poorer retention in buprenorphine, particularly in the early years of buprenorphine in Australia. There were just over 1,000 opioid overdose deaths during this time. So I'm going to present 4 of these tables. I know there's a lot of numbers there. So the first 2 tables are going to be the results for the age group analyses, and then the second 2 will be by the chronic disease analyses. And then within each set of 2 tables, we'll look at the mortality rates while in OAT compared to time out of treatment. And then in the second, we'll look at mortality rates in methadone compared to buprenorphine, so in treatment mortality. So if you look at the middle column, the crude mortality rate column, you can see that overdose rates increase with age, whether in or out of treatment. And then looking at those last 2 columns with the GEE and the marginal structural models, you can see that the rate ratios are, as you would expect, well below 1. The confidence intervals are also well below 1. So just confirming that being in OAT with either methadone or buprenorphine is associated with a reduced risk of overdose death. That's not really a new finding, except for that 50-plus age group. It's quite a useful thing to be able to show that that's a consistent finding as people are ageing. Then looking at comparing buprenorphine and methadone, you can see that, again, all the confidence intervals contain 1, which might suggest that there's not much difference between buprenorphine and methadone in terms of their ability to reduce overdose deaths. But I do want to point out that these rate ratios are consistently below 1. It's probably best to characterise this as weak evidence of a difference rather than no difference. And in particular, if you look at that bottom row for people over 50, at least in the GEE model, it's pretty close to excluding 1. So it's not really strong evidence that buprenorphine is superior to methadone in preventing overdose, but it's probably not really fair also to characterise it as no difference between the medicines. Looking at the chronic diseases and comparing time in treatment to time out of treatment, again, across all of these diseases, being in treatment is better than not being in treatment. That's a general finding, as we expected. If we compare buprenorphine to methadone, though, there's some really interesting things to notice. So for people with kidney disease or liver disease, it looks like there's probably not much difference between methadone and buprenorphine in terms of opioid overdose deaths. If we look at... I was meant to highlight that for you to make it easier. Looking at people with circulatory and respiratory diseases, though, it does seem like buprenorphine may have an advantage over methadone in reducing opioid overdose deaths. You can see that the crude overdose mortality rates are less than half during bup compared to during methadone. And the rate ratios reflect that quite clearly as well, whereas the rates for liver and kidney disease show much more overlap between the 2 treatment types. Obviously, it's important to bear in mind that these comorbidities were ascertained using hospital data, so this underestimates the true burden and dilutes the associations that we were able to observe, which might explain some of the, weak evidence results. There were a couple of key variables that we weren't able to include in the models. Dose is something that we don't have. Also severity of opioid use disorder, use of other central nervous system depressants, which might also increase overdose risk. So if those differ by, if the people in buprenorphine treatment are different systematically from the people in methadone treatment on those factors, that may explain greater risk during treatment with methadone. So to summarise, the way that we're characterising this is that it's weak evidence of a difference between treatments favouring buprenorphine in terms of opioid overdose risk in that older age group. And we also found reasonably strong evidence of lower overdose risk with buprenorphine than methadone in the presence of respiratory and circulatory diseases. So this suggests that buprenorphine may be the preferred first-line OAT when prescribing for people with respiratory or circulatory comorbidities. But it is very important to bear in mind that, particularly if you're talking about older clients who have been on OAT for some time, people probably have their preference already as well. And if you switch people without you're really talking about that decision, that's going to cause problems. And people leaving treatment because they're not getting the treatment they want is not a good outcome. So there does need to be a discussion between the prescriber and the client. And if the decision is made to switch, there are now protocols to assist that and transition and reduce potential withdrawals or other discomfort. But if someone does decide they'd rather stay on methadone, then there's also various harm reduction things that can be done. So additional support to reduce overdose risk in methadone, whether that's take-home naloxone, information for carers or other people in the household. And also I was thinking about medicines review to minimise interactions that might exacerbate respiratory depression. So as you probably can imagine, loads of people involved in this work. Funding was through NIH, and we thank all of the data custodians and the Centre for Health Record Linkage, and also the OATS Aboriginal Reference Group, who have reviewed all of our papers and given really interesting and helpful advice that's helped to contextualise the findings and avoid being a bit, culturally tin-eared. So thank you.
Thank you, Sarah. That was excellent presentation. Are there any questions for Sarah, either online or in person? I might ask a question. Did you look to see if there was a gender effect, given the conversation we were having earlier?
Yeah. We didn't look at gender specifically extra. No, it's in the model, but we haven't looked at it stratified. I suppose maybe with the older group, would it get too small? It might get a bit small by age groups. Yeah. But yeah, it might be interesting because obviously there's a difference there in mortality rates. Yeah, all right, I'll put that on the list.
No questions? Nope. No.
Awesome.
Thank you, Sarah.
Thank you.
So our next presenter will be Ms. Nano Minoyan, who will be joining us as a pre-recorded presentation. Nano is a PhD candidate at the University of Montreal, whose research focuses on the contextual determinants of drug-related risk behaviours and harms among people who inject drugs in Montreal. And her presentation is on binge drug injection in Montreal.
Hello everyone, and thank you to the organizers for the opportunity to share this work. This presentation focuses on high-intensity episodic injection patterns, or binges, which have been associated with psychosocial harms such as suicide attempts, psychological distress, and depressive symptoms in studies among people who inject drugs, with various binge definitions being utilized across studies. Binge episodes may contribute to bloodborne virus transmission, for instance, through known or unknown exposure to contaminated materials, or uninhibited drug and sexual behaviors. Binge drug use may also be a precursor to overdose and may constitute a target for behavioral intervention. Binge drug use hasn't, however, been particularly well characterized in the scientific literature. Our study therefore aimed to describe binge injection episodes among people who inject drugs in Montreal, Canada, and to examine social contexts of this behavior with the rationale that prevention of viral transmission as well as overdose deaths through naloxone inherently involve contacts between individuals. We used data from the hepatitis cohort, which since 2011 involves 3 monthly interviews with active people who inject drugs who are recruited through a variety of strategies. For our binge definition, participants were asked whether in the past 3 months they injected large quantities of drugs without stopping over a limited period of time until they no longer had drugs or were no longer physically able to continue consuming them. Those saying yes were then asked a series of follow-up questions. The study sample was comprised of 805 individuals providing over 8,000 observations. and participants had a median age of 40 at the first post-2011 visit, so the baseline of this study. 42% were unstably housed in the past month, 82% were male, and 92% were Caucasian. At the first post-2011 visit, 15% of participants reported binging in the last 3 months, with 35% of participants reporting binging at least once over the course of follow-up, for a total of 590 binge events. 42% of participants reported only binging alone in the past 3 months. Among the remaining, there was a similar split between romantic partners, close friends, family, and other friends, acquaintances, with 9% injecting with a consumption partner and 3 participants reporting injecting with a stranger. There were some gender-based differences, however, with women more often injecting with a romantic partner. 76% of binge episodes involved a single substance. When we consider all substances together, participants most commonly reported injecting cocaine, plus or minus other drugs during binges, followed by prescription opioids with 26%, heroin 21%, and amphetamine 7.5%. Examining this through mutually exclusive categories, about half injected only cocaine, 1/5 only opioids, 18% injected heroin or opioids with cocaine, and few participants reported injecting amphetamines or other combinations during binges. Almost 2/3 reported additional non-injection substances, with alcohol, marijuana, and crack cocaine each being involved in about 1/4 of binges, and these are non-mutually exclusive. When asked about potential exposure to bloodborne viruses, 16% of participants reported that they did not always know where their syringes were during binge episodes, and 17% specifically replied that they did use syringes or did not know whether they had used syringes already used by someone else to inject. In some, binge drug injection episodes involve a diverse range of substances and social contexts. Binges predominantly involve stimulants, which is the class of substances more commonly associated with this binge type consumption pattern. However, a non-negligible proportion in the study self-identified their opioid use as meeting our binge criteria. And more generally, opioid use was common during binges, regardless of the other substances used. Naloxone distribution efforts should therefore aim to reach a large number of people who inject drugs, regardless of their opioid use history, to maximize population-level benefits in the case of overdoses. However, the high proportion of participants binging alone is concerning and warrants additional prevention strategies in this study. Thank you for your attention, and I'd like to thank the study participants as well as the study staff involved in collecting the data for this study.
Thank you so much, Nanor, for that really interesting presentation. Nanor was unable to join us today, but we do have a couple of minutes for discussion. If anybody in the room or online has any comments or potential questions, areas of interest, please feel free to stand up or submit them. No? No worries. We might leave that one there. We did start a few minutes late, so we can try to play a bit of catch-up. So moving on to the next presenter, Dr. Andrew McCauley has worked in the addictions field since 2005. Andrew is an experienced mixed methods researcher with particular expertise on injecting drug use and related harms. Thank you so much, Andrew.
Good afternoon, everyone. This is just going to be a quick presentation on a subject that's come up quite a lot over the course of this morning in terms of benzodiazepine use, and you'll be delighted to know there are no pictures of me in my pyjamas in this presentation as there were this morning. So just to acknowledge, I've got no declarations of interest, and special thanks to the people who inject drugs who have generously participated in this research over the past 12 years. Now, the use of benzodiazepines is a global issue, but in Scotland it spans almost 3 or 4 decades now. This is not a new phenomenon. People who use drugs have been using benzodiazepines since the 80s, the 90s, all the way through, and a whole host of different benzodiazepines have come into favour and fell out of favour over the course of that timeline. So I just wanted to highlight the context and the history of this. And partly in response to that use and some of the problems or harms related to that use, back in around 2005, between 2005 and 2010 anyway, there was a decision taken at that point to address prescribing of benzodiazepines, because it was felt that prescribing of benzodiazepines at that time was being diverted onto an illicit market, and their presence in drug-related deaths was causing concern. Now, bear in mind, in 2005 there were around 350 drug-related deaths per year in Scotland, and around a quarter of those featured a benzodiazepine. Now we have 4 times as many drug-related deaths in Scotland, and around 70% feature a benzodiazepine. So it's quite clear to see that the unintended consequences of that policy decision far outweigh the intended consequences. And this graph really illustrates that. You can see the any benzodiazepine line. This is the involvement of benzodiazepines in drug-related deaths in Scotland. And you can see the involvement in any benzodiazepine really rockets up from around 2014. And it's really that red line, or the dashed red line, where you can see what's responsible for that. And it's street benzodiazepines, or illicit non-prescribed benzodiazepines, very much dominated by a drug called atizolam. And that decision to restrict prescribing came at the same time where NPS were becoming much more available in the country through the internet and other means. So very much a perfect storm for addressing the supply issue but not addressing the demand. And why street benzos matter? Well, they matter for many reasons, but certainly they increase one's risk of overdose. They're often more toxic drugs than the drugs they're replacing. They often behave differently. So in the case of atizolam, it has a much shorter half-life, so people redose much more frequently on it. So they're taking much more of the drug in more frequent episodes. When we also did some qualitative work in this area, people talked about taking these drugs in handfuls, not in ones or twos. I'll take a handful in the morning, I'll take a handful at night, because these drugs are very available and very affordable to the people who use them. And there's also this thing about false advertising. We call it a consumption roulette. Very much in the early days, and even until now, although people are more informed, the drugs were designed to look like the drugs they replaced. They looked very much like the diazepam pills they were replacing, but they contained very different substances. And this is just one example of a range of different seizure data you can get, which shows a drug that was being sold as street Valium, so street diazepam, contained much more than street diazepam, and was a very dangerous tablet in its own right. And there's lots of different examples of this you can see, where people are literally taking handfuls of very different quantities of drugs than they would maybe have been used to in a diverted market of prescription medicines with a degree of quality control. So despite all this problems about street benzos, we have very little knowledge about who's using them and how many people are using them. We had to rely a lot on police seizure data for many years in Scotland. So we aimed, jumping a bit quick there, we aimed to determine the prevalence of this use in the country and who was really using them within our population of people who use drugs. And we used our NESE surveys for this. So NESE is the Needle Exchange Surveillance Initiative. NESE is a biobehavioural survey we do every 2 years through the university. So we send a team of researchers across the country to sites providing injecting equipment, and we ask people to participate in a short interview, and we take a dry blood spot sample from them. And this is the way we monitor incidence and prevalence of bloodborne viruses, but we can also understand lots of other issues in relation to drug use behaviours and service engagement. So the characteristics of people who reported street benzo use. So you can see the street benzo users are the column on the right-hand side compared to the total sample, and I've just highlighted in red some of the things that really stand out. So you can see around half of the people we interviewed reported using a street benzo in the last 6 months. They were less likely to be male, actually, more likely to also report excess alcohol, frequent experience of imprisonment. And you can also see down the bottom some interesting ones there. They were also much more likely to have experienced a non-fatal overdose in the last 12 months, and they were also much more likely to have ever been prescribed benzodiazepines. So that very much fits with this hypothesis that it's a group of users who used to use the diverted medicines or who used to be prescribed these medicines and have now changed to a street-based market. Then we also modelled some of this data to see what predicted street benzo use amongst this population, to see what the strongest determinants were. And you can see here, the strongest determinant was people who reported injecting in a public place. So among our homeless populations, our most vulnerable and marginalised populations, they had almost 3.5 times more odds of using street benzos than other people who inject drugs we interviewed. Also, people who had recently been in treatment were also reporting use of these drugs. And as I said, that link between people who had historically been prescribed benzos and also the link between incarceration there. And then interestingly, we've seen a reduced risk related to age. So every year people increased, they had a slightly reduced risk of these drugs. But then importantly, we also done some additional modelling in relation to non-fatal overdose to see how much street benzo use predicted one's chance or risk of a non-fatal overdose. And you can see here we had a significant finding here of around a 2.5-fold increased risk of non-fatal overdose amongst people who use street benzos compared to those who didn't. So to summarise, there is high demand for benzodiazepines in Scotland. There always has been, and there continues to be high demand. And I think we heard in this morning's session a lot of the reasons why people use benzodiazepines, whether for pleasure or whether therapeutically. But there has been this shift from a diversion of kind of quality-controlled prescription medicines to a very toxic illicit market. And this high prevalence is very much concentrated amongst our most vulnerable populations, those very much vulnerable to drug-related deaths, and goes part of the way to explaining what's happened over the last 6 or 7 years. And as we pointed out, street benzo use looks to be associated with non-fatal overdose, and we know non-fatal overdose is associated eventually with fatal overdose. So what have we recommended about this? So there's a larger volume of work to address this issue in Scotland because it's such a big issue at the moment. And there's some short-term recommendations and some long-term. The short-term recommendations are very much linked to what I talked about this morning in terms of safer prescribing, drug checking services and drug consumption rooms. And just to reflect what's been done in those, there are now safer prescribing guidance out there through the Drug Death Task Force, which is trying to be worked into something more formalised with the Royal Colleges, although that is a very difficult process because the evidence base isn't necessarily there for long-term prescribing of benzodiazepines, so it's going to involve a bit of trade-off between the clinicians adopting a more harm reduction approach to prescribing there. Drug checking services, there is great progress in Scotland and there should be some sites opening early next year. If you're interested in that, I think Tessa Parks and Hannah Carver are at the conference and can tell you more about that. And drug consumption rooms, we're very hopeful, will open at some point. Our drug consumption room will open at some point in the next 12 months as our new Lord Advocate appears much more receptive to the idea than the previous incumbent. And then obviously again, longer term, I think we really need to be addressing the inequalities that are fueling the demand in this epidemic in the first place. Thank you.
Thank you, Andy. Does anybody have any burning questions for Andy? We are running a little behind time. Is there a question at the back? Yeah?
I really wanted the bell, Jack, but I didn't get one. Thank you.
Sorry if I'm not helping your timeline here. I'm Andrea. I'm a safer opioid prescriber in Canada. So I'm really curious, and I apologize if I missed the nuance here. But my understanding of your presentation is that people are injecting primarily benzos alone, sometimes with opioids, but mostly benzos alone. Would that be correct?
No, so people are not injecting benzos. Mm-hmm. So the population we studied were a population of people who inject drugs, mm-hmm. but they're using oral benzo tablets.
I understand. So oral benzo on top, yeah. And I'm just curious because we've seen the same inflection once intizolam came into our fentanyl supply in Canada. So for me, it starts to ask the question of what is our killer here? Is it fentanyl and it is, or obviously both? So thank you. That was very interesting.
Yeah, and just to follow up, it's very unusual to see somebody dying from a benzo alone. It's almost exclusively people taking benzos alongside other drugs. Yeah, thanks.
Okay. Yep, thanks, Andy. So So our next presenter is Dr. Philip Brugman, who's the head of internal medicine at the Arad Center for Addiction Medicine in Zurich, and is also a research fellow at the Institute for Family Medicine at the University of Zurich, and also co-founder of INHSU.
Thank you very much. Good afternoon. It's a great pleasure to present you the essentials of this study on mortality rates and causes of death in a Swiss OAT cohort overlooking 22 years. We have no conflicts of interest to declare in relation to this study. The methods of this study in this retrospective treatment cohort study with individual level linkage of different data sources, we investigated 3,965 patients who have been at least once on OAT between 1992 and 2013 at our Arad Center in Zurich. And we observed death rates and causes of death over this 22-year period. We used an extended exponential survival analysis, and we developed a statistical model which allowed simultaneously estimating all-cause mortality rate and the fractions of common causes of death categories. 739 patients who died during this period have been included in this study. The all-cause mortality rate was 15.0 per 1,000 person years. We found the all-cause mortality rate increasing with age, but no effect on of sex, treatment status, treatment duration, and a calendar year. The age-controlled all-cause mortality rate was stable during OAT, but sharply increased in the year of discontinuation, with a non-linearly diminishing over the following years, showing here in this curve. The common cause of death categories. The proportion of common cause of death categories were only related to the calendar year, and within that we observed a decrease of overdose and HIV-related causes, seeing on the left side here, HIV and overdose going back, while liver-related and other internal medicine causes increased during the observed time showed here. So I conclude from this study there is still a relevant excess mortality among our OAT population compared to the general population, but we have to intensify the focus in general internal medicine care in this OAT population to encounter increased mortality rates in those fields. So that's very short the essentials of our study. Thank you.
Thanks very much, Philip. Was there any questions from the audience, either in the room or online? Yeah, can I ask you to go to the microphone or here?
Thanks for the presentation. Can you just say something about what the other internal complications that you have? Liver disease and then other. Was there some main
It's
things?
mainly lung disease and kidney disease, which were the main causes of internal medicine causes.
Hi, nice presentation. Wonder if you'd be able to speak to the massive increase you saw in liver disease over time. Was that an aging thing, or?
I think it was mainly, the liver disease was mainly due to a combination of hepatitis C and alcohol.
Alcohol too, okay, because for hep C alone that would be quite a large increase, so alcohol was also
Yes, alcohol is quite a common issue among our population. Yeah.
Thank you.
Any other questions? Yeah.
Thank you. Sophia Bartlett from the BC Centre for Disease Control in Vancouver. I noticed that the data is ending in 2013, so I'm just wondering, like, what was the rate of hepatitis C treatment in that time period? Because I'm just presuming that it would have been fairly low in that population.
Yes, thank you for this question. Of course, that had an impact on the liver-related mortality, because this was during interferon treatment, and there I would say the treatment uptake rate was about 60%. Now it went up to over 90%, and this of course had an impact on liver-related mortality.
So my follow-up question is, like, have you got updated data or to see, like, has the liver-related mortality come down
Unfortunately not, because it was very complicated to bring all these data together, and we will see whether we can do that once again, but unfortunately we only have this data so far.
In British Columbia, our liver-related mortality was increasing in the same period. Like, our data up until 2013 mirrors what you saw in the Swiss cohort, but we've actually since seen overdose mortality far exceeding liver-related mortality now.
Okay. But we still observe in our daily practice that overdose mortality is going back in Switzerland.
Thanks very much for the questions, and another round of applause for Philip, please. Thank you. Our next speaker is Teresa Flynn. She's a peer recovery worker at Hillcrest Future's Harm Reduction Service and involved in coordinating and delivering recovery-based activities in the community. Thanks so much, Teresa.
Thank you. Good afternoon. So my name is Teresa Flynn. I am a peer researcher at the University of Dundee, and today I'm going to present the research on overdose that we done in 2021. This was funded by the Scottish Government, Scottish Drug Death Task Force. So a little bit of background. So Scotland has 3.7 the number of drug-related deaths compared to the UK as a whole. And Dundee City, unfortunately, for the past few years has had been known as the drug death capital of Scotland. And we wanted to find out what were the experiences of overdose in people in Dundee. So the methods that we used was two peer researchers used two separate injecting equipment provision services. We interviewed 20 individuals who we paid £20 each in cash, and we got 500 minutes of data. We used thematic analysis to analyse this data. The results that we found, we had 5 overarching themes. One was social context, who people had around them, their networks. The second was personal risk-taking triggers, what made people more likely to use more. The third was planned and impulsive consumption. People had habits for using, but also used impulsively when presented with the opportunity. Fourth was risk perceptions. Everyone knew they were at risk of overdose, but personal tolerance, awareness was low. The fifth was reversing overdose. Naloxone was well known and acceptable for people to use and to be used on. The conclusion was there was a complex interplay of internal and external influences observed in the study. Social and physical environments played a significant role in risk-taking behaviours. Interventions on overdose. Risk reduction should shift to target the interpersonal skills involved in drug using behaviours, which led to increased risks of overdose. Thank you.
Thank you, Teresa. That was very interesting. Are there any questions, either online or in the room, for Teresa? Yep.
Thank you, Teresa. I am wondering if you could comment on what you think the experience is for peer researchers participating and conducting and leading research like this, because I'm just interested in like the kind of additional benefits that you think there are to peers leading research.
I think the benefits of peers leading research is that, one, the participants, you can identify with them because you've been there and you've already done it, and people trust you because they know that what you're talking about, you've been there and you've done it, and you've felt what they're feeling at that moment. It's a lot to do with trust.
So better data.
Or better data. Amy?
Thank you.
Thank you.
Okay. Can we just thank Teresa once more? Now, the last speaker of this session is Dr. Sandra Springer, who is an Associate Professor of Medicine in the Department of Internal Medicine at the Yale School of Medicine.
You got to say a lot of medicine.
Medicine.
I know. I'm standing between you and coffee break or something. Thanks. Yeah, so on behalf of my co-authors and also the participants of whom identified as using drugs with opioid use disorder, I'd just like to, thank them very much. So these are my disclosures, and they include this current trial is being funded by the National Institutes on Health. So this is Project Commit, and thanks to the second speaker for setting this up. This is a multi-site randomized controlled trial, basically assessing a new model of care of integrating infectious disease and opioid use disorder treatment in adults who are hospitalized with opioid use disorder and concurrent infections. And it's in 3 sites in the United States, Pennsylvania, South Carolina, and Connecticut. And the intervention is we're randomizing individuals 1-to-1 to the integrated care model, which includes long-acting buprenorphine, and it's an FDA-approved formulation in the United States, Sublocade, that's administered subcutaneously in the abdomen every 4 weeks, integrated with their infectious disease treatment, or treatment as usual, which includes the treatment for their opioid addiction, buprenorphine, methadone, in the hospital. All participants also, regardless of their randomization arm, receive opioid use disorder education, effective treatment education, naloxone, prescription overdose education, as well as nurse care, discharge, assertive discharge, planning for outpatient infectious disease and opioid use disorder treatment, and weekly medical management contact to assess how they're doing, as well as needs assessments, including transportation and housing assistance. The primary outcome is looking at a binary outcome of receipt of a form of medication treatment for opioid use disorder at the end of the 12-week intervention arm. And then the other outcomes include opioid outcomes, as well as overdose and completion of antimicrobial regimens, rehospitalizations, infectious disease outcomes, and others. So the intervention is for 12 weeks, and then we do a 24-week assessment. And the protocol paper is published there. So this is just the early feasibility and acceptability data, because this trial is still ongoing. It started enrolling in August of 2020 when COVID hit. And we are currently enrolling through the next year. Of the 113 individuals who met eligibility, 107 of them consented to participate in this trial, so a 94% acceptance rate. Almost 50% identified as female, which we're very excited about. 40% identified as being homeless in the past 30 days of hospitalization. Almost 67% met moderate to severe criteria for depression. 50% had comorbid stimulant use disorder. And when we look at the self-reported substance use data from the timeline follow back, the majority are reporting heroin injection as well as fentanyl and stimulant use. The infections at baseline, so we do a detailed infectious disease assessment, are highlighted the top 4 in red here, bacteremia, endocarditis, and concurrent active hepatitis C infection, as well as abscesses, and these are abscesses, not soft tissue abscesses. Looking at the feasibility data, we follow everybody for 24 weeks. 12 weeks is the, as I said, the intervention arm. 80% of the participants who are enrolled in this study are still actively involved at 12 weeks and 74% at 24 weeks. There have been no serious adverse events thus far related to the intervention arm. There have been 3 deaths, however, unfortunately, 1 due to sepsis, 1 due to acute respiratory distress syndrome, and another of unknown cause. And I know I only have a couple of minutes, so I just left you with the conclusions. And if you have any detailed questions, again, about the protocol or anything, you can talk to me afterwards or right now. Thank you.
Thank you so much for that. Any questions in the room or online? No? Well, if anything comes to mind, we are conveniently at a coffee break. Thank you, everybody, for attending, and to all of our speakers. This was the Drug Use Trends and Overdose session. Thanks for attending.